Good morning, everyone, and thank you for joining us at Cardiology Grand Rounds. We are very lucky and fortunate to have a wonderful speaker today, Dr. Joynt Maddox, who is a cardiologist and assistant professor at Washington University in St. Louis, the co-director of the Center for Health Economics and Policy at WashU, and also the associate program director of the Cardiovascular Medicine Fellowship there. Dr. Joynt Maddox graduated from Princeton University, attended medical school and internal medicine residency at Duke, and completed her cardiovascular medicine or cardiovascular fellowship training at Brigham and Women's Hospital. And she was on faculty at the Brigham and the Harvard School of Public Health for a few years, and then was asked to serve as a senior advisor at the Office of Health Policy at the U.S. Department of Health and Human Services in DC for 2 years, prior to joining the faculty at WashU. So I'd like to add a few more things on top of Karen's bio. Karen is a prolific researcher who has published more than 170 papers and is the PI of multiple R01s from the NIH. But even more importantly, I think many of us know across the country that Karen has impacted and changed health policy at the federal level for the better, both through her empirical research work and her roles in government at HHS and CMS. At the same time, she's really inspired an emerging generation of cardiologists and trainees to develop an expertise in healthcare policy to be used as a tool to improve healthcare delivery and equity. And I can say that because I'm one of the many individuals who Karen has really inspired, who has benefited tremendously from her mentorship and generosity. And I know Bobby and I are really grateful that she's been a close collaborator with us at the Smith Center over the last few years. Now, I'll just add that on top of Karen's many talents, Jeremy Robbins recently shared with me that they were on a softball team together and that she's a phenomenal softball player, and Karen is a self-described sports nut. And that's probably because, as Alec was alluding to earlier, she grew up in Ann Arbor as a Michigan fan and then spent a lot of time at Duke, which sort of has this mediocre basketball team. And so I've never been able to convince Karen to tell me where her sports loyalties lie. So at the end of her talk, during the Q&A, which we can do both via chat or video function, whatever you guys are comfortable with, feel free to ask her to publicly disclose whether she's a Michigan or Duke fan. So thank you so much, Karen, for taking the time to speak with us today, and I'll turn it over to you.
Great, thank you for that very kind introduction. I will gladly disclose sports loyalties. I'll also say that I have the fortune or disfortune of marrying a Yankees and Cowboys fan, so it can be tough. All right, let's get started here. So I'm going to talk about the role of health policy in improving equity and outcomes in cardiology. Here are my disclosures. As Reese mentioned, I did spend a couple years working for the government. It'll be fairly obvious, so I'm not speaking on their behalf. And I do have grant funding related to some of the payment models that I'll talk about today, but no commercial financial disclosures. So I'm going to keep it pretty simple, talk about some health inequities in cardiology to set the stage a little bit, and then talk through some of the potential policy solutions that I think are most important. And some of these will be pretty familiar to all of you, some maybe a little bit less so. I'll also leave hopefully a pretty good amount of time at the end and talk about some combination of sports and policy, however people want to play that one. So let's start just by going through a little bit of our failures actually in health inequities over the last 20 years. Equity has been a bit of a buzzword in the last couple of years for very good reasons, but obviously we've known about health inequities for a long time. And I think these graphs, which were published just a month or so ago in JAMA Network Open, really demonstrate what a failure we have made of our efforts toward equity in cardiovascular risk factors and cardiovascular disease over the past couple decades. So in these graphs, you're looking at white individuals in the blue lines, Black individuals in the orange lines, and Hispanic individuals in the sort of tan lines. And then they're broken up by age group. So 45 to 54 on the left, 55 to 64 in the middle, and over 65 on the right. And that'll be the same pattern for the next couple slides. And so you can see that from 99 to 2018, there has been no closures in these gaps, right? So we're looking at diabetes in the top panels, just huge differences in the incidence and prevalence of diabetes for men and women across all age groups. And if anything, really widening disparities in this important cardiovascular risk factor. And same thing for hypertension. In this case, the Hispanic and white lines run a little more closely together. The Black population remains much, much higher in terms of hypertension, again, across all age groups, with no evidence that we're making any progress, despite being well aware of these inequities. Here, if we look at, I guess these aren't technically cardiovascular, but asthma, which I guess I would have, as a prior, thought would be the most disparate, actually is not, but we haven't made progress there either. And then stroke on the bottom. And again, really not seeing these gaps close, particularly again, between Black and white individuals. Another thing that was examined in this paper was the rate of having insurance, which obviously is not a cardiovascular outcome in and of itself, though we'll talk about why it's so crucial in that area. And you can see here that there are, just massive gaps in insurance rates. For example, there are years in this study where the uninsurance rate in the Hispanic population is over 30%, compared to closer to 10 to 12 for the white group in this study. And this is national survey data, so it's representative. You can see a big dip in all groups, especially the younger groups, around the time of ACA implementation, which we'll talk about a little bit later. And then, of course, the smallest gaps in the 65 and older, because for that group, we really do have close to universal coverage. There are some differences, particularly among immigrant communities, and other ways that people sort of have to qualify for Medicare, but really close to universal coverage in that group all the way on the right. Then some work that Rishi led, looking at some of these issues by poverty. So here we're looking at 1 year all-cause mortality rates between people in Medicare who either do or don't also qualify for Medicaid, which indicates that you're quite poor. So about 20% of the Medicare population also qualifies for Medicaid. And you can see here between 2004 and 2016, a big gap, almost double the mortality, and really no meaningful closure there. And if you look at outcomes conditional on being hospitalized for acute MI, CHF, or pneumonia, again, you can see really no change in pretty major gaps over time for each of these conditions, suggesting that we've really failed to address inequities with all of our policy and clinical interventions over the past couple decades. Finally, I'll add rural to the mix. This has become even more evident to me since moving from Boston to Missouri, which is a definitively more rural state, politically and geographically. And you can see that there's really been an emerging inequity in terms of outcomes for rural areas. So I think this is a fascinating curve. I don't know that I would have guessed it, but if you look at deaths per 100,000 over the time course from the 1970s through the 90s, really, there was no difference between rural and urban death rates. And we can talk about why this gap has emerged. I think it's a complex interplay of sort of technology and sort of social circumstances. But you can see that a gap really starts to emerge, and that you see almost a 20% difference in death rates in rural versus urban areas by the end of this study, which went through 2016. If we then break this up into high and low poverty, you can see that the rural high poverty group, which is that top orange line, really just has strikingly higher mortality rates. And again, there's been a difference between rich and poor throughout the course of this graph, but really starts to diverge impressively after the early 90s. Okay, so you knew all that, right? I didn't just blow your minds with some exciting new data. Like, you knew that was the case, right? We know this from our clinical practice. We know this from our day-to-day experience. So let's think a little bit then about how did we get here? What underlies these differences? I think we hear a lot, particularly in cardiovascular medicine, about diet and exercise and tobacco use. We know that those things are higher in minority communities. We know they're higher in rural communities. We think about stress. We think about inflammation. And more recently, we've even tied those to sort of the lived experience of being a minority, particularly Black in this country, and sort of the day-to-day stress that comes with racism and other experiences, demonstrating physiologic effects. So we can sort of add those to the list of ways that these mechanisms might work, if you will. We can think about environmental exposure. So we know that minority communities have higher levels of exposure to air pollution and are closer to awful sites, things like that, sort of a variety of environmental exposures around pollution and, Superfund sites and things like that. We obviously know that poverty independently impacts outcomes through a bunch of related mechanisms that are closely tied to and sometimes difficult to distinguish from the effects of race and morality. We could think about lack of education or lack of access to primary care or lack of access to specialty care or lack of access to quaternary care. All of the things that as our medical system becomes more technological, these things matter more. It didn't used to matter a lot who you saw if there was bloodletting and leeches, but if we're talking about, endovascular therapy for strokes, there's a big difference in who has access to those technologies. But what underlies all of these things is structural inequity. We got here for a reason, right? Babies aren't born wanting to smoke. People aren't born in rural areas inherently more stressed out. Children in rural areas don't want to be poor. Black babies born don't want a lack of access to specialty care. These are not things that are inherent about the communities that they hurt. There are things that are built into the communities into which people are born. And if you think about the way that these are sort of destiny from the very beginning of people's lives, I think you can realize that all of these things are just a symptom of much deeper structural inequities in how health is impacted in our society. So that brings me to the early punchline here, which is why are health inequities a policy problem? It's because they're reflective of systemic, broad, longstanding issues. And with absolutely all due respect to the people who are coming up with new inventions every day that make our health better, we are not going to solve health inequities with clinician will alone. If we want to do better, that's not going to change things. Inventing a new drug isn't going to do it. Inventing a new device isn't going to do it. Inventing a new surgical technique isn't going to do it. Inventing a new imaging modality isn't going to do it. Those are all things we should do. And like I said, I have immense respect for the people who are able to do those things, as I am not. But they're not going to fundamentally change health equity, and they're not fundamentally going to improve our outcomes as a population unless we think differently. We have to structurally undo what was structurally done if we want to actually move the needle on cardiovascular risk factors and cardiovascular outcomes. So a primer on health policy. I will say I learned a lot of this when I went to DC and was like drowning in the alphabet soup of those first few meetings, much like when you're like a medical student and you read your first H&P and there's all these like S/Ps. What the hell are these people talking about? There's a similar experience going to work in government for the first time, but I learned a lot and I think some of it is relevant. So health policy are the federal, state, and local statutes and regulations that determine the rules of the game. We don't see them much. They're certainly more obvious now than they ever have been before. People used to look at me like I was crazy when I said I did health policy. Now everyone's like, oh yeah, no, I get it. So statute is law. Only Congress or other legislative bodies can pass laws. So things like the Affordable Care Act, big things, come out of Congress. And then agencies like CMS or the FDA or the CDC have to implement what's written in law. So to some degree, we're stuck with some of these laws that very well-meaning staffers wrote at 3 o'clock in the morning. The ACA is sort of a Frankenstein law. It was never meant to be implemented as written, but because of Massachusetts politics, it got put through in sort of a strange way, and so it's a bit of an odd bill. Regulation is the details of implementation, and that's done by agencies like, again, CMS, FDA, CDC, whoever. So something like payment rates for a stroke hospitalization in Medicare doesn't have to get legislated every year. There's much more discretion. You're seeing right now at the end of this administration, CMS coming out with a huge number of new regulations around telehealth, around payment models, around things that they can do under regulatory authority that don't require Congress to act. Sometimes that's good, sometimes that's bad. And I'm sure it's happening in all the other agencies as well, though I certainly don't track those nearly as closely as I do the health side. I'm going to talk for the rest of this session then about sort of 3 buckets of health policy that I think about. The big missing bucket here is public health policy. So things like tobacco control, gun control, a whole bunch of stuff like that I'm not going to get into today. But the other 3 buckets that I think are really crucial for cardiovascular health are coverage and access policy, payment and care delivery policy, and social and economic policy. And so I'm going to go through each of those in turn and talk a little bit about where I think where we are, some level setting, and then where we might be able to go to try to improve cardiovascular health. So if we bucket our big policy problems into those three color-coded bubbles, I think we can narrow it down a little bit for the purposes of the conversation today. So when we think about access, so that access and coverage bucket, the red one, our biggest sort of core issue is that minority communities and rural communities lack coverage and access. They have much lower rates of both insurance, as I showed, and access to care. In the blue bucket, or the sort of payment and care delivery policy, we have issues with quality. So we know that there's inadequate quality of care, uneven quality of care across the country, and that it's much worse in under-resourced areas. And then finally, in the green bucket, we know that there's resource disparity that underlies all of this. So some communities and groups just have a lot more resource than others. And the way that our policy in this country is built, as opposed to many other countries, a lot of things, schools, healthcare, are sort of intensely reliant on local resources in a way that don't necessarily need to be, but they are because of the way that we've built policy. So if we want to talk policy solutions, which is arguably more interesting than sort of revisiting all the problems as I have thus far, we'll talk about three areas. So Medicaid expansion and access to care, which is interesting to talk to Massachusetts people about Medicaid expansion, but you'll get a bit of a view for how the rest of us are stuck here. Quality of care, including public reporting, pay for performance, some other efforts and policy efforts in that area and why they're not improving equity or outcomes. And then resource disparity and why we need to think a little more broadly about this, though that's certainly the area about which I know the least, so that'll be brief. Okay, Medicaid. Again, I probably don't have to explain this to all of you, but I'm going to for level setting purposes. So Medicaid was created in 1965. It's a state administered program to provide healthcare coverage to the poor. So this is not Medicare, which covers everybody over 65 and then a few groups younger than that. It's funded about 60-40 federal and state, and the asterisks there is to remind me that that ratio can vary quite a bit by state. So richer states, Massachusetts, pays more of its own Medicaid bill. Poorer states, Missouri, pay less of their own Medicaid bill. Actually, we're somewhere in the middle. It doesn't go all the way from 0 to 100, but there's definitely differences in who pays how much. This is one of the places where that sort of net donor versus recipient in terms of federal money plays out in big dollars, because this is big dollars. Medicaid covers, at last count, though it's gone up from this, 76 million beneficiaries, half of all births, and 60% of nursing home care. So Medicare doesn't cover nursing home care other than immediate post-acute care. So if you send someone home after a heart attack, if you send someone to a nursing home after a heart attack, they have a post-acute care benefit. If they have to stay past their benefit, it's not covered. And so much of nursing home care is picked up by Medicaid, if people even spending down to get on Medicaid to be eligible. Benefits and eligibility differ somewhat, and by somewhat I mean massively, by state. All states cover pregnant women and most children up to about 300% of federal poverty, but they vary broadly in coverage for other populations. So this is what expansion looks like as of November 2020. I guess I could change it to December since nothing changed in the past 4 days. Missouri is shaded there in a crosshatch because we have passed Medicaid expansion by popular vote as of last summer, and it is due to be implemented in July. So we've been working with the state on this to some degree. The plans are basically due to the feds in March. It's a tough time to think about Medicaid expansion, right? We know that Medicaid rolls have gone up by 5 to 8% across the country during COVID, and they're going to go up more as people roll off COBRA and sort of encounter health problems when they are uninsured. And so this is going to be a really huge problem for state budgets for 2021, which we can again talk about later if there's time. But you can see a distinct geographic pattern to decisions around Medicaid that are not going to help disparities. This I was shocked by moving to Missouri, so I'm just going to put it out there in case you all don't know this either. Eligibility in non-expansion states ranges incredibly. So if you are, as I mentioned, pregnant, you're covered up to roughly 300% of FPL, which for an individual is FPL is $12,000 for an individual and about $21,000 for a family of 3 in 2018. Those have gone up a hair. But once you get past the 6-week postpartum coverage, you fall into the custodial parent group. In Missouri, you're covered up to 22% of federal poverty, which is not very much money. It turns out my math is not terrific, but that's like, $4,000 or $5,000 a year. There is no way that someone making $4,000 or $5,000 a year can purchase health insurance. There's no way. I mean, that's insane. Trying to keep food on the table and pay rent, which is hard enough on $4,000 or $5,000 a year. So there's a huge gap in non-expansion states between people who have access to Medicaid and people who have no statutory way to qualify, who are just sort of left out in the cold. And if you look at childless adults, on the right-hand side, you don't qualify no matter what. You can make zero, and you do not qualify for Medicaid in many, many states. There are no options for you in terms of being able to get coverage. Now, the ACA, which expanded Medicaid and also put in marketplaces to try to shore up the individual market, which is a bit of a mess, did reduce uninsurance from been floating between 15 and 16% and dropped down to closer to 8. It's bumped up a little bit in the past couple of years and will bump up more this year as a result of COVID, but certainly an improvement with much more to go. Now, we know that the benefit of Medicaid expansion accrues to people with low income, which makes sense. So if you look at these lines, you can see the folks under federal poverty in the orange, and then above in the blue, recognizing that plenty of people who are poor are in the blue bars. But for the purposes of this illustration, looking at those who are under 138% of FPL in the orange, just a huge gap between expansion and non-expansion states in terms of insurance rates going from over 35% down to 15%. That said, insurance remains hugely uneven across states. I've highlighted Missouri and Massachusetts, so you can just see two. For example, Massachusetts is at 4% or something like that at last check, maybe 3%. In Missouri, we're more around 10, and Texas has the, I don't know, I'm not quite sure what to call it, the award for highest uninsurance rate at over 18% across the state of Texas. That is many, many, many people without coverage. So why does this matter? Well, we know that insurance really matters for health, and it really matters for cardiovascular health. I've put it all on one slide. I could have expanded this out into an entire talk. What we're learning about the impact of Medicaid on health. So there's unequivocal evidence for financial protection, right? That's what insurance does. And there's, I would say, unequivocal evidence for financial protection of hospitals, actually. And so in rural areas in particular, where hospitals are historically low occupancy, low margin, barely getting by, Medicaid expansion has been associated with fewer hospital closures. So it's been a big deal in expansion states to keep access alive, not only in terms of people having access, but in terms of having somewhere to go with their insurance. I'd say there's strong evidence for a lot of the first things that happen with insurance in sort of a temporal fashion, right? So better access to primary care, more ambulatory care visits, more use of prescription medications, better medication adherence, more access to preventive care. And a lot of these are cardiovascular in nature. So getting your diabetes and hypertension and dyslipidemia diagnosed and treated, which has obviously huge potential long-term effects, would sort of fall in this bucket of where we see pretty immediate gains. Moderate evidence for better self-reported health. The effect on mental health is actually pretty immediate because it turns out that not having insurance is incredibly stressful. And so just taking that away leads to a pretty acute improvement in mental health, even before you talk about people being able to get treatment for depression, anxiety, opioid use disorder, all the things that we have also seen improvements in when people have insurance. Mixed evidence for utilization. I'm not sure utilization should really be an outcome in quite the same way. We actually want people to use healthcare, right? If we're trying to get people healthier, there needs to be some use of healthcare. So emergency department use and hospitalizations actually sometimes go up when people get coverage because they seek care and find out that they have high blood pressure. They need whatever stent. So utilization goes up, which is why these things are cost effective, but not necessarily cost saving. And then growing evidence for lower mortality, including cardiovascular mortality and cancer mortality, two areas that together comprise a huge amount of the death and disability in this country, and both of which can benefit immensely from earlier intervention. So earlier stage of cancer diagnosis, earlier intervention on diabetes, hypertension. We won't see the actual effects of these things for many years, and it's tough to tease out when you throw things like the global pandemic into the middle of it. But there's certainly growing evidence that this makes a big difference. And the impacts are largest for racial and ethnic minorities and in rural areas. So we are starting to see things like infant mortality, gaps closing by race and ethnicity in areas that have expanded Medicaid. So this is a huge deal. And I mean, in my personal opinion, you won't be shocked to hear that I think it's completely shameful that we haven't, as a country, come up with a way to get everyone covered. It's actually both, I think, a moral imperative and an economic imperative. If you think about the drag on the economy of people being sick and not having access to care, of not being healthy, of all of the sort of follow on of this that I know you see in your hospital beds, just like we see in ours. So this, to me, and that's why I put it first, is the most crucial way that health policy will ultimately impact cardiovascular and broader health. So if we turn then to sort of the quality setting, so let's assume that people have access. Let's assume that the rest of the country has followed Massachusetts's lead and gotten people covered, and we know that now they can come to the hospital. What are they getting when they get there? Is it high quality? Is it optimized? What are we going to do there? And a big part of the ACA was in this area, as many of you have lived through. So value-based and alternative payment models, to take sort of a veer off from Medicaid, using financial incentives to ensure that the care that is delivered is of the highest possible quality. Seems like a terrific idea. And if we think about what this pathway has looked like over the past decade, say, we've moved a lot of payments down this pathway. So if we start with fee-for-service in red on the left, that is, you do a chest x-ray, you get paid for a chest x-ray. You do a cath, you get paid for a cath. You deliver a baby, you get paid for delivering a baby. We move over to the public reporting bucket in blue. We start putting your performance on those particular elements online. We don't do anything about it, but we put it online in hopes that it will incent improvement. We move to the green bucket, which is where most of us in hospital medicine live all the time, which is in value-based payment. And we'll talk a little bit about some of the most famous or infamous groups there, where you adjust payments based on quality or based on a measurement that people call quality. In the purple buckets, I'm bucketing a lot today, in the purple buckets, we move into episode payments, which are thinking about accountability for a 90-day episode of care. You know, cabbage and childbirth and a bunch of things are already paid this way. So it's not that wild and crazy, but moving more things into that bucket. And then finally, global payments, things like ACOs are not quite there, but some of the ACO models, some of the alternative quality contract, like many things, more so in Massachusetts than any place else in the country, have moved more into this bucket of sort of total cost of care and accountability across a broad population. So they literally updated the Hospital Compare website, like, I don't know, this week or something. So when I went on to get screenshots for this, it was all new. So now if you go on Hospital Compare, and I would encourage you to do this for your local hospitals as well as, I don't know, I looked it up for where my parents live. It is interesting to see all that you can find out about hospitals. So if you put in the Boston zip codes, if you put in 02115, actually, because I was trying to cone down on your local area, this is the map that you get, and you can see the hospitals that are available to you and how far away they are and a bunch of stuff like that. You then get into what used to be pretty graphs and now are just sort of boring tables, apologies, but a bunch of information that you can get about hospitals. So here's BI, BMC, and the Brigham looking at, you know, death rate for COPD, death rate for heart attack patients, death rate for heart failure patients, for pneumonia patients, for stroke patients, for cabbage. And you can see for each one what the actual death rate is among Medicare beneficiaries and whether or not that's different than the national rate. So for example, the heart failure mortality rate at BI is 8.7%, which on a risk-adjusted basis is actually markedly better than the national rate of 11.3%. And that's in the whatever third row down, I guess. So you can go through all of these and you actually get a tremendous amount of information about volume and about how hospitals perform. Now, as nice as that website is, it has done nothing as far as we know. So this is some work that we did a number of years ago, looking at the time period under public reporting, which was process only reporting. So when you logged onto that website and you could just see whether or not people gave beta blockers and aspirin and I think door to balloon time and a few other early measures. And then we moved into process and mortality reporting as of 2008. And I don't even really need to tell you which of those two lines is the reported conditions or the non-reported conditions, like which ones were on the website and which ones weren't. There's no difference in the improvement in risk-adjusted mortality rates based on whether or not the conditions were included in those programs. And this has been replicated by other groups and in other settings. There's really no evidence that public reporting has meaningfully improved patient outcomes, nor has it improved equity. Now, if we move one notch farther down my sort of paradigm of value-based payment, we get to the hospital readmissions reduction program, which I know is well loved by many people on this particular event. So the HRP is a penalty program for hospitals with quote unquote excess readmissions. And it's a sort of wonky formula where the penalty is based on dollars spent on excess readmissions as a function of total dollars. It started with heart attack, heart failure, and pneumonia. Added COPD, hips and knees, and bypass surgery. And it's currently penalizing 80% of US hospitals. So it's not clear that it's only penalizing excess readmissions, to be fair. And penalties are capped at 3% of base DRG payments, which is the sort of starting point for Medicare payments. And that's real money. So I would call the penalties from the HRP anywhere from negligible to major. Should come up with a catchier word for major. But basically, as you look across your local hospitals, I should add 2021 here, you can see hospitals, including your own, getting pretty high penalties. And that's real money. And it's not just the heart failure admissions that are dinged. So if you get a penalty based on heart failure readmissions and acute MI readmissions, if a surgeon does a splenectomy, their money gets taken away. If you admit a patient for a pacemaker, your money gets taken away. So this affects the entire hospital, not just the folks who are included in the calculation. There was a policy change in 2018, so you can see some sort of jumps around that same time related to a change in how penalties are calculated. Now, there was initially quite a bit of enthusiasm about this program because the first data that came out suggested that after announcement, not after implementation, interestingly, there was a significant drop in readmissions among targeted versus non-targeted conditions, which are in the blue versus the red. It completely stopped after implementation, and we can argue about whether that's because people decided that it was, an averted readmission is also an averted admission, which comes with payment. So there are some funny financial incentives. Getting hospitals to cut their own admissions is a bit of an odd ask, and reducing readmissions is hard. So maybe that first drop when the program was announced was when we started doing discharge planning and sending everyone home with like a legible list of their medications. And then the hard stuff, like making sure people have outpatient care and can afford their medications and have a place to store insulin, all those things are where we're left. But more concerningly, and this is some work that Rishi led, there is the possibility that at least for heart failure, this program has actually been associated with rising mortality. So looking at the timeframes in the pre-HRP period and then through its announcement and implementation, there has been an increase in death among heart failure patients. And it is interestingly, seems to be centered around the group of people who have death and no readmission. So the concern is that when people are coming back to the emergency department or calling their physicians, if they are within 30 days of an admission, there's a big disincentive to bring them back into the hospital. And so maybe we're putting people on OBS or we're even sending them home from the ER. And maybe sometimes we miss, maybe on the margins, there are patients there who should have been admitted. Not that anyone's doing that and making bad decisions on purpose, but it is possible that decisions are impacted around that time that could have negative consequences. This is obviously observational, but I think concerning. And given that we haven't seen any ongoing improvements in readmission rates, and now we see an increase in mortality, it's not clear to me what this program is buying us. The other issue is that this program has major equity problems. So safety net and teaching hospitals are most likely to be penalized. And from work that we and others have done, it's not clear that this is due to worse quality. It seems actually fairly clear that the majority of these differences are due to bad risk adjustment. We don't account for the patient population being different at safety net versus non-safety net hospitals. We don't account for complexity at major teaching hospitals. We don't account for complexity at major referral hospitals. We put things in the model like whether or not someone has diabetes, not whether they've had multiple amputations for diabetes. We put in the model whether or not someone's 65 or 85, but not whether they're frail, not whether they are from communal living, not whether they're in a nursing home. All the things that we know impact outcomes. And in this day and age, I think it's kind of absurd that we're relying on risk models that were developed in 2002 that used to take me a weekend to run when I was a fellow and would leave SAS running for the weekend. And now anyone can run in a laptop in an hour. So we have a long way to go in trying to make this program more equitable. Moving one notch further down to episode-based payments. So a bunch of the Boston hospitals have been in some versions of these programs. The bundle payments for care improvement program was a voluntary program launched in 2013. Cardiac was a big chunk of them, actually the biggest. Heart failure, ICDs, pacemakers, valves, heart attacks, PCI, a whole bunch of stuff in cardiac was in there. And it's a 90-day episode for which hospitals take accountability. If you beat the targets, you keep the money. If you do worse, you pay the government back. Participation was modest in round one. It's been about double that in round two. It maybe modestly reduces cost. Our initial study went through the sort of 12 to 18 months, and collectively it did not reduce costs in any group. But as we followed the longest enrollees out the farthest, it does look like in the sort of 2 to 3 year timeframe that they're starting to save some money. We're talking about, $500 on a basis of 25,000. So it's not like a massive improvement, but it looks like it may, after time, modestly reduce costs, mostly by reducing post-acute care use. But it's not at all effective in improving outcomes. So we've managed to save $500 on a base of 25 or 30,000, but with no differential improvement in 90-day mortality, in 90-day readmission, or in healthy days at home. And in some cases, the BPCI group has actually done worse. So really no evidence to suggest that these programs have on balance improved outcomes. And if anything, they've been, as will be a theme today, they've been really bad for equity. So this is data from a mandatory bundle. There weren't very many safety nets in the voluntary bundles. But in the mandatory version of this, safety nets were 2.5 times more likely, at 2.5 times higher odds of receiving penalties, and 40% of the odds of receiving bonuses in these programs, because they're just not fair. And so these programs have just served to not improve outcomes, not really improve costs, and take money away from the safety net. All of these programs are grossly inequitable. They just are. I've stopped sort of sugarcoating my words around it the farther I've gotten out from federal employment. They all penalize the safety net compared to the non-safety net. They all compare apples to oranges. And when you improve the risk adjustment models by putting simple things like, is the patient enrolled in Medicaid? Does the patient have a hospital bed at home? Things that indicate markers of poverty or disability, we see that between 1/2 and 2/3 of the differential performance between safety nets and non goes away, which is enough to account for, I don't know, probably millions of dollars in our 1-year evaluations of these simulations. It probably adds up over time of penalties toward the safety net, which they can ill afford. So we need a complete rethinking of this branch of policy to make it improve outcomes and equity. The programs have not improved outcomes, and they have potentially worsened inequities, and they're a huge administrative drag. So what are we doing? We need equity at the center of these, not as an afterthought. If we want care to improve for people who are doing poorly currently, that's where we need to focus. We need high quality, rapid feedback, actionable data. I assume that you all get your HRP feedback like we do, which is like, you get it, say in 2021, we just got our penalties for this year, which reflects our readmissions from 17, 18, 19 what does that tell me about how things have changed? What does that tell me about quality improvement? Who got readmitted? When was it? Why? It doesn't do anything in the way that you'd actually think about trying to change care. We need accountability to high fidelity processes. I'd argue that we should be demanding that hospitals can provide imaging in time for people who show up with a stroke. You can get people to the cath lab. You can do the things that hospitals should be good at doing. And we should demand very high fidelity to certain processes of care. And then we should give global payments and rewards for innovation where people can improve outcomes. I think that sets up these systems much, much more fairly than saying that we can measure 30-day readmission and compare those numbers between different hospitals with any sense of fairness. So in our last bucket here, again, the one about which I know the least, so I will spend the least time, but I actually think is probably the most important in the meta sense, is resource disparity. So we need targeted and intentional multi-level investment to actually undo some of these differences. There's nothing about trying to prevent a readmission that's going to fundamentally undo the effect of 60 years of lived racism or growing up in a rural area without resources on someone's cardiovascular system. So as I've said many times, structural problems won't go away without structural solutions. We're coming at them from the wrong side if we think that's going to happen. And the structural problems we see are not accidents. They were put in place on purpose by the people who are writing the laws. Now, they may have not been meant to be as pernicious as they have turned out to be, but they were not put in place on accident. They are not immovable. They are changeable just like anything else. So we need to intentionally change healthcare access. We need to intentionally make sure that there are clinics and access to hospitals in minority communities, in dense urban areas where there are pockets of a complete lack of access, in rural areas. There's plenty of money in this country to ensure that people have basic access to healthcare. The most difficult one is economic opportunity. That's obviously a multi-generational investment. There's been a lot of very interesting studies looking at family wealth. One actually around the Boston area that compared family wealth between Black and white families. And it was like a few $100s to hundreds of thousands of dollars on average. And that's intergenerational, it's multi-generational, and it can only be fixed by meaningfully changing economic opportunity. A little bit more, I don't know, tangibly isn't quite fair, but specifically perhaps, we need to train clinicians from historically excluded groups, and that includes racial and ethnic minorities, and it includes clinicians from rural areas. If we want patients to seek medical care, if we want patients to engage with medical care, if we want patients to trust medical care, if we want patients to get vaccinations, we have to look like them. We have to be part of communities. We can't say, well, there's a history of mistrust because of Tuskegee. That is true. How are we fixing it? How are we changing it? And part of it is making sure that the medical community is comprised of a bunch of people who are pulling in the same direction. It's not just saying like, hey, trust us now. That's not going to work. We need people leading from within who represent all different parts of the community. And the only way we're going to get there is by changing how we're doing things. And that means things like, putting medical schools in historically Black colleges and universities. It means creating new training programs in rural areas. It does not mean doing the status quo and saying everyone needs to adapt to meet the sort of, wealthy urban version of medical training. If we look at this in terms of data, you can see on the left, racial and ethnic breakdown of the population versus physician breakdown with Black, African-American, and Hispanic Latinx in the green and blue bars, just grossly underrepresented in the physician community, particularly in the older physician community. There's been some gains in the younger group, although not among Black men. And then on the right-hand side, you can see rural versus urban. So about 20% of the population is rural, about 10% of the physicians and about 5% of the medical students are from rural areas. So we are not heading in the right area and in the right direction in terms of making sure that we have people in medicine who both understand and wish to remain engaged in treating these particularly at-risk groups. So health policy is, I think, I'm obviously biased, a crucial tool to improve outcomes and reduce inequities in cardiovascular disease. We should do all the other things. We should do discovery. We should do all of the science. We should do it all. But if we don't also include health policy in our mission as cardiologists and as physicians, we're not going to make the impact that we would hope. What was structurally done needs to be structurally undone. I hope if you take anything away that is sort of something you remember from this talk. And the time frame is long. Like, I was really frustrated sometimes in government when we talk about how long it takes to get things done, but the opportunity for impact is huge. And so having focused discussions with clinicians in the room who understand how medicine works, about how we can change the system in the long run, I think is the only way that we're going to meaningfully close these gaps. So I would like to thank my research team, my Center for Health Economics and Policy team, my Boston crew, who was sort of formative in everything that I have done in medicine, particularly folks at the Smith Center, and then the folks who are not on that list who have been later additions to my life and extremely positive ones, including Kazi and the other folks in that office. You guys are awesome, and it's been a pleasure to get to continue to work with you and watch you build like an empire of researchers working in these areas. I look forward to questions, and I tried to leave significant time, so bring on sports or policy queries.
Thank you so much, Karen, for a really phenomenal talk. Really, I mean, all of your work has been at the forefront of health policy and equity. And I think, like I said before, we see it in our fellowship applications. There are so many cardiology applicants now who want to do health policy. And I think that's a testament to you trailblazing this pathway for so many of us, along with Bobby, who has been doing policy research for a while now. I will start. I have a question from Warren Manning that I'll start with, and I have a few questions too. And feel free to either send your questions in via the chat or just pop on video and ask your questions. So the first question from Warren was: does public reporting only include inpatient care? Are there outpatient care dashboards, which could potentially be important for outpatient providers?
There is not a Medicare-wide outpatient dashboard right now. There's a lot of reasons why outpatient care is a lot more complicated in terms of the billing and knowing who's attributed to whom and how many clinicians bill under multiple TINs. So it's behind. You can go on to Physician Compare and download some stuff, but it's not quite as user-friendly. I shouldn't say there isn't one. There is. It's not quite as complete as the hospital one or the nursing home one, which is actually quite good. There's home health, there may be hospice. So I'd say it's not terrific. Outpatient care is so much more variable between practices than inpatient care. And the government, in trying to do sort of a one-size-fits-all program for outpatient practices like it has for hospitals, has essentially come up with a fairly meaningless program, because how are you going to compare quality measures between urologists and radiologists and general internists? So it's a bit of a mess right now. But I would say that over the next few years, I expect that'll be a big area of focus for public reporting, for better or for worse.
Other questions before I go into mine?
I've
Please.
Yeah, Karen, thank
Hi,
you so much. Hi. I just wanted to reiterate, I mean, we're so grateful for all of your intellectual leadership and partnership with stuff we've done here. And that was a really phenomenal talk. I want to ask a question about, there's been what seems like an eternity that we've been debating whether or not things like social risk factors and race and poverty should be adjusted for in these measures. And the countervailing argument, of course, is that adjustment for these factors give credit to hospitals that aren't taking care, delivering as high quality as they should be to disadvantaged groups. So I know you've been the leader of arguing against that, and you've done so again here today. Where is the government on that? Where are we nationally in that debate? Is that debate over? And give us an update on that.
Yeah, it is a very live debate, and I expect that there will be movement on it in a number of ways over the next 12 months. So, yesterday, whenever the final, the payment rule and all of its stuff came out for outpatient payment, I swear this is connected. It sounds random, but it's not. There was a shift in how we pay for outpatient care, right? So there's been like a simplification of how you bill in the outpatient setting, and cardiologists are anticipated to make 1% more, blah, blah, blah. You all probably got notifications on it from ACC or whoever else you get notifications from. One interesting thing sort of slipped in there that actually came from the AMA was that you can bill a higher level care in the outpatient setting now for social risk factors. So you can code them. There are Z codes for like lack of housing, for history of abuse, for all sorts of things that we know impact our patients' outcomes. And you don't get credit in the outcome adjustment, but it is now officially made it into payment policy quietly because the AMA put it in. CMS was like, sure, that seems cool. On the flip side, so on the risk adjustment for the hospital stuff and ACOs and whatnot, it remains a very active area of debate. National Quality Forum had come out and basically said that they think it should be accounted for, that it's just patently unfair not to, when there's evidence that social risk factors impact outcomes in ways that cannot be addressed by the hospital at the time. It's not to say we shouldn't work on it. It's to say that on a single admission, I'm not going to fix all of the history that goes with social risk. ASPE, my former employer, then came out with a report that said they shouldn't. And then NQF basically has put together a new group to try to look at this and come out with something definitive, which I'm chairing. So they wouldn't have selected me for that if they didn't have some impression that was the side on which they think that the science is, because they know what I think. So I think it'll be an area of active debate over the next 12 months. Ideally, actually, to be totally fair about it, it's one of the reasons I keep arguing for process measures, even though I know people kind of hate them, because we actually need to know in two totally separate buckets. Is the hospital delivering high quality care and how are their patients doing? And those things are not one-to-one. They're just not. And so considering them as part of the same continuum and treating them the same way is absurd. If we understand what hospitals are doing, we understand the quality they're delivering. If we understand their patients' outcomes, that is a much broader set of issues. And so in my opinion, we need to separate the two and actually be focused on both. One around fidelity and absolute adherence, and one around creativity and innovation and broader thinking.
Go ahead, Kazi.
Thank you, Karen. That was super interesting. Can I ask you two related questions? One is slightly quantitative and one is big picture. The quantitative, the penalties that across all of these programs, one can think of as taxes. And when, as you know, when economists think about taxes, they think about deadweight loss from administering the taxes. And she's done some work on like how much money is going into both from the hospital side and the government side on like administering these programs. Do we have a sense of like, because then the $500 difference on the $25,000 gains might disappear once we incorporate the administrative costs. So one question was, is there a quantification of this deadweight loss from administering the programs? And the second is perhaps a big picture question on like, what explains the resilience of these programs after like almost 5 to 10 years of data that they're not doing very much for quality and probably hurting equity? I'd like to think that
those are such logical questions.
Yeah, I'd like to think that the government agencies are filled with people who actually intend to do well, like do good. Like, so what's the resilience of these programs?
Yeah, so those are both terrific questions. They assume a level of nimbleness that doesn't exist in the government, I will say, but they're both excellent questions. The deadweight question is a great one. We have a building of people, and I'm sure you all do too, a building of people who are employed only to work on these programs, right? And it's a lot about like coding and billing, and you can't let a bill go out till you see if it's got a potential adverse event in it. So you do a chart review to take it off if it isn't, because it's going to penalize. Just insanity. And lots of manual data extraction. The administrative costs are clearly far beyond anything we've saved from these programs. You're absolutely right. But it's not government money. It's societal money, right? We're spending, our health system is spending in order to make that change. And that's not captured at all. The CMS internal administrative costs are what they are. They're pretty low, actually. It's the external costs that the government doesn't see that I think are astronomical compared to the benefit. So I completely agree with you on that. I've not seen accounting done. The question of why they're resilient is an interesting one. I found when I was in government that it was the most like hardworking, mission-driven people, a group of people I'd worked with, right? No one cared whose name was on a paper. It was about like, how are we improving healthcare? It was actually a very refreshing break from academia. The trick was that no one knew how healthcare worked. Like none of them were doctors or nurses or physical therapists, or they had no idea. And it felt very logical that if you just put a penalty in place for readmissions, people will work harder and reduce them. And if we put some things into a model, it'll make it fair across hospitals. I would literally say, probably on a weekly basis, to the senior economist who ran the office I worked in, will you come to an ER with me? Any ER. We'll just go to a series of them. We'll sit in the waiting room. How can you not understand how patently unfair and silly these programs are? But that's not who's writing them. They also, because of the issue around statutory versus regulatory, these are now written in law. And so Congress would have to go change them. We can't stop them. We can't change them. Some of the formulas are written into some of that law, which is a sticking point for the HRP. So the other big issue is that we need a functional Congress who has the headspace to think about this like kind of wonky area that's working without causing too much controversy to actually change it at this point.
Thank you.
A quick comment, Kazi, also related to your question, is that Larry Castellino has this famous health affairs paper that showed where he surveyed a bunch of outpatient providers and found that he, per his estimate, a core group of 4 different type of specialty outpatient providers were spending about $15 billion a year total to report quality measures and sort of deal with quality measures. So it's pretty interesting.
And if that was meaningfully improving health, it could be a totally reasonable investment. What we have is a mishmash of things that are effective and things are not. I don't think anyone would argue you don't need to measure. Like if you're not measuring, you have no idea what's happening, right? Like, I don't know, what proportion of your patients, of your heart failure patients go home on beta blocker? I brought this up in one of our grand rounds and one of the senior physicians said, high quality physicians always know what their patients are taking. I was like, oh, come on. No, you don't. You don't know which intern was on when they got discharged. You don't know whether they ever picked it up. Like that's silly. If you don't have data, you don't know what's happening. So there is there's a way to use this stuff to make things better, right? But that's not how we're necessarily using it.
I have a question from Jeremy Robbins, who I know was a softball teammate of yours. He says, Karen, your talk was outstanding, probably better than your softball game. What are the most effective ways physicians and nurses can wield their power towards just policy reforms?
That's a great question. I can't tell if it's a compliment of the talk or an insult of my softball game, but I will say that Jeremy is an outstanding softball player if anyone's looking for a good teammate. So, I mean, this ranges, right? There's sort of straight up advocacy, and sometimes that can be very effective. Just having, clinicians, and ACC and AHA both do this, where they have advocacy days where you can go talk to your elected officials. That's surprisingly powerful to have physicians, nurses, and other sort of clinically engaged people just show up for a day. It's even easier now that it's virtual and you don't actually have to travel to do it. So that can be incredibly effective. I think other than that, it's just become so much part of the national conversation now that we're starting to change the dialogue around it. And that means the more people that are engaged and involved and understand, the more that ACC, AHA, the AMA, the nurses associations, the more that these groups have really changed their stance. And that's how you get Congress to change their stance, is by sort of changing the constituent view on how these things should be. And since we do need congressional action ultimately to change some of these things, it's a combination of both embedding people in government that know what they're doing, getting more physicians into leadership positions in government, and nurses and physical therapists and all that. And then also working to from the groundswell side to actually influence people who are in Congress. It's a great question.
Maybe we'll end. I don't know if anyone, Warren had one more question. Does anyone, I'll throw it out there. Are there data, and I know you know this literature well, that adoption of hospitals, that hospitals adopting EMRs or access to other hospitals' EMRs led to improvements in healthcare?
Yes and no. So it's not clear that it's led to improvements in outcomes. It's pretty clear that it's led to better, at least, documentation of processes of care. And there's emerging data about health information exchange and data sharing and a reduction in basically duplication. I will say, it'll take a while for that to play out, but it certainly made a huge difference for us switching to Epic and being able to actually see what patients have had and who they are and what's going on. There are some emerging data around that, the data sharing piece. The outcomes, there's not, I think, much of any good data on meaningful across the board changes in outcomes as a result of EHR. So a little more efficiency, much better billing, if you want to talk about some of the unintended or intended consequences. Hospitals make a lot more money when they use EMRs because they can bill so much more effectively. That's the reason they do them. They're very successful at their intended purposes.
Thank you so much, Karen, for taking the time to speak with us today. It was an amazing talk. And I know there are trainees who I can see in the Zoom audience that have been a big fan of your work for a while. And I always encourage them to reach out to you. But thank you again for taking the time to work with us and be part of the BI and Smith Center family, and for taking the time today. And we'll obviously be in touch with you very soon.
Thank you, everyone.
Take care.
Happy Friday. Stay safe.